So welcome to the breakout session.
Great.
And I also want to thank our sponsor, AstrZeneca, for providing the speaker for this session. I'd like to introduce Dr. Amit Saxena from New York Langone. Dr. Saxena is an academic rheumatologist at NYU Langone Health. He completed his rheumatology training at NYU and transitioned to specializing in the care of lupus patients after completing a Pfizer fellowship in rheumatology, immunology, focused on the disease. Dr. Saxena is the director for lupus clinical trials and has been the site principal investigator in over 25 industries. NIH sponsored and investigator-initiated interventional and observational trials. He is also the co-director of the clinical trials design course for the NYU Master of Science of Clinical Investigation program. And he is currently studying steroid-induced osteoporosis in lupus patients using a novel 3T MRI protocol and has received several grants to study long-term outcomes in patients with neonatal lupus. So Dr. Saxena, I'm going to pass over to you.
Thank you so much. Thanks for having me. This is really exciting. It's always great to kind of be able to talk to patients more in a group than one-on-one, as much as that's always fun too. But just kind of here to kind of talk a little bit more about lupus in general, but also dive into some more specifics if people are interested. Talk about kind of the interface between what patients want out of their treatment, what doctors are looking at when they're trying to treat patients, and how we can make those things jive together. And then just talk a little bit about where we're going and how we think we're going to be able to kind of tackle this disease in a way that we haven't in the past. So I'm going to share my slides, and I'm going to talk a little bit about lupus in general, and then again, overall topic, which we're calling Unlocking Lupus, which is key learnings in systemic lupus. And as we go along, feel free to type stuff into the chat. I'll take a look at it at the end, or we'll have some questions at the end, I'm sure. I think we should have some time for that. If something is really urgent, or you feel like you need to jump in, go ahead and do that. But we're going to try to keep this a little bit friendly and not super formal. So this presentation is supported by AstrZeneca, but we aren't going to be talking about any sort of drugs or anything like that. This is more about lupus in general. And so we're not going to be kind of diving into names of medications or anything like that. And we're going to talk about things in groups. We're going to break things down a little bit and talk first about, lupus and the burden of lupus, something that I'm sure most of you guys know about in general, but it's always kind of a good overview to take a look at and kind of differentiate the types of lupus that people have and how everybody's lupus can be different, even though, we all kind of call this one disease or under one umbrella. And then we're going to talk more about the immune system itself and why we think this is happening and how we're learning about, the differences in the effects of the immune system that causes the inflammation and damage that lead to the symptoms that everybody feels. Then we're going to talk again about some of the ways that we treat lupus, the way we think about lupus, and the tools that we have now. And then we're going to dig into what we think is going to happen in the future and how we're going to try to manage this disease, not just with new medicines, but with new ways of kind of understanding what patients feel and how, what we're going to do about making sure that we're not just thinking about, getting lab tests to be normal or seeing things differently on the exam. We really are trying to focus more on, how we make patients feel better overall.
Dr. Saxena, can you change your view to presenter mode? It'll make the slides a little bit bigger for.
Interesting. I thought I was, but let me try this again. Maybe what I'll do is I'll share my screen. Sometimes that's the issue. Let's try this. Is that better?
Perfect.
Okay, great. Sorry. Okay. So The first part about understanding lupus is trying to get a gauge on what makes lupus it's a unique disease, because it's not a disease that affects everybody the same. In this group of 20 people here, each person is going to have their own symptom complex. Each person is going to have, different ways that the disease affects them on a day-to-day versus on during different times during flares. And the symptoms can be variable, and we're going to talk a little bit about all the different types of manifestations of the disease. But it is a key point of what lupus is that it makes it more difficult to understand, more difficult to treat, and I think more difficult for other people to understand you as patients when you try to tell them what your disease is. And so, trying to get a little bit more of an understanding about that maybe could help with some of that understanding between all of us. What happens when people feel a certain way, or when things don't really make a ton of sense, is that can cause disconnects again between patients and doctors, between patients and their family members. And it makes it very difficult when you're feeling something and somebody else says you look fine, or your lab tests look great. I don't know why you feel like that. And that's a source of frustration that I think can lead to patients getting, not wanting to even take part in this medical system, and kind of losing trust with the people that they should be trusting the most. And so, I think over time, it took us time to really understand this and to hear what patients are saying about this stuff, so that we can now at least take a step back and think about where we can go from here. And so we know that 65% of people say that chronic pain is probably the most difficult part of lupus, and it's really that chronic pain part of it that is the hardest to get a gauge of, right? We all know when a flare happens, when joints get red and hot and swollen, it becomes obvious for us that we got to do something about this. But it's in those time periods sometimes when those flares aren't happening that patients are still feeling pain, and we as doctors might say, oh, everything looks fine, so we're not going to do anything about that right now. And along with those types of pains comes the fatigue, and the fatigue that we don't really understand. We're going to talk about the immunological changes that can happen with lupus, and we can kind of go from point A to point B as to why some of those things might lead to fatigue, but we really don't have an answer of, so if we can just stop this from happening, it'll make your fatigue go away. One thing we know about our lupus patients is we can make all those swollen joints go away, we can make rashes go away, but people will still have that fatigue, and we don't quite understand that, but we need to acknowledge that that's what is really limiting patients, forcing them to cut back on their social activities, having them stay away from work. These are kind of the real world things that we're going to have to try to address going forward. And along with that, as I mentioned, working, this is our ultimate goal with treating lupus, is to make sure that people can just do what they need to do and do what they want to do. And when people can't work due to their lupus, it affects everything about them. Unfortunately, we're so tied into what our work is, and it's so much of who we are in this society, that if we take that away from people, and they can't do that, it can lead to just multiple downstream issues where not only does mood get affected, but then with that comes not wanting to take part in the medications or do things, and then that can lead to kind of a vicious cycle of just not getting better. So we are understanding that these things are issues, but obviously we have a lot of ways to go before we can address these in the correct way. But that's going to be our ultimate goal from here, more so than just finding the right medicine. So over the past decade, we've had a lot of new research, and particularly new medications that have come out, which are extraordinarily exciting. I mean, in these last 10 years or 11 years, we've had more drugs that are approved for lupus than have been approved in 50, 60 ever, really, in the past. And with that, we know that certainly if we can get the right medications on board, we can do things like reducing those disease flares that can happen, reduce disease activity, probably in some ways, most importantly, reducing those side effects and steroid uses that we need to use when things are really active, because those are the things that can sometimes lead to damage of the organs, which is really our ultimate goal, right? Our ultimate goal is to prevent you from ever needing to need a kidney transplant or need or have things that just don't ever get bounced back to the way that they were before. And I think that's a goal that we all can agree with, that we all want to make sure is at the forefront of our treatment options. And so how we do that is by understanding different people's lupus, and again, and that's what makes lupus more difficult than just treating somebody's blood pressure or even treating their diabetes, which can be difficult because lupus can be so variable between people. If we can really get a sense for how to treat each person specifically, we can really reach those goals of treatment to prevent those damage and all those side effects. So we're going to talk a little bit more detail about the immune system, because I think, when you are taught about lupus, or when your doctors teach you about lupus, or even in a program like this, I think, a lot of times we'll focus on the treatments and some of the bigger picture issues, but we often talk about how the immune system is attacking yourself. And sometimes we kind of leave it at that and just say your immune system is attacking yourself, it's causing inflammation. But if you're here on a Saturday morning, that means you might be a little bit more interested in knowing what that means and why understanding that can lead to better treatments. And so I'm not going to go into crazy amounts of detail, but I still think it's interesting to kind of talk about what we know about lupus, how it's caused, and where we can take that to understand how to treat things better. And so again, we know that lupus is a complex autoimmune disease. The immune system attacks itself, tissues, organs, and what we really don't 100% know is why it happens. We're still trying to learn this. There's lots of research going on all over the world, really interesting stuff that we learn every day, really, new articles that come out about, what makes lupus different for different people and how the inflammation is causing damage in the body. And there's a lot of different ways to kind of couch this, but one of the ways that I like to talk about it is what we call it a two-hit phenomena, right? And so the first hit is that you have some sort of genetic predisposition to getting an autoimmune disease. And we know that autoimmune diseases cluster in families. It's not always necessarily that it's just lupus that clusters. It's not that like everybody gets lupus, but a lot of times we'll see one person in the family have lupus, maybe somebody else have another autoimmune disease like rheumatoid arthritis or thyroid disease, childhood diabetes. So there's something about autoimmunity that is in the genes and gets passed on. But it's also not 100% the reason. Even in identical twins, maybe about 35% of patients of those identical twins will both have lupus, for example. And so, there's got to be more to it than just your genes. And so what is it that triggers the immune system to become abnormal, to start working in a way that it's attacking yourself instead of just doing its normal job? And that's where I think a lot of the research is coming in. And what is it? Is it something in the environment that we just don't understand yet? There's a lot of talk about viruses, for example, viruses that come on and turn on your immune system to fight them, and then maybe trigger your immune system to not stop afterwards and keep fighting and start fighting yourself or fighting a part of your body that might look like the virus, for example. We know about things that can trigger flares, things like sun exposure, which when it causes damage to your body, the immune system kind of turns on to clean up that mess, and autoimmune stuff can turn on too. Other infections that turn on the immune system. So all of these things, or some of these things, or none of these things could be the reason. And so we're still trying to figure that part out. But what happens when the immune system gets turned on is that these inflammatory, signals get sent, and these inflammatory cells get activated and start causing damage to our own body. And so that's what we're going to talk about next. And so You don't have to memorize this. It's not going to be a test at the end. But again, I think it's kind of interesting to think about and look at the immune system, how it works, how it's supposed to work, and then how things can go wrong when you have lupus. And so we have a bunch of different cells, different types of cell types that are used to essentially fight infections, which is our ultimate goal for the immune system in general. And all of these cells do different things. They all kind of overlap because they're all trying to do the same job, but they all have a little bit of a different role to play. And so you can see here, all of these in this picture, kind of happy looking, cells just doing their thing and kind of ready to go. And when we think about these cells, there's a lot of different ways we can kind of break down what they do and how they work. But I think a good way to think about it is that there are two different sides of the immune systems, or two different types of the immune system. And both of these types of the immune system kind of have the same role, again, is to fight off bad guys when they get into our body. But they are different in how they were formed and how we have them. The innate immunity, which is the side on the left, these types of cells that are involved in the innate immunity, is kind of the defense system that everybody is born with. Everybody has these types of cells, and they're ready to go, as soon as you're born, to fight off, bacteria, viruses, and they're in a lot of ways non-specific. They will attack any foreign invader the way that they can. On the right-hand side is something that's called the adaptive immunity. And that's the defense system that you develop. It happens over time, as you get exposed to some, bacteria or virus. These are the types of cells that see them, they learn them, and then they know how to fight them off in the future. In a lot of ways, that's also how vaccines work. You get a vaccine that shows you a protein. These types of cells, these B cells and T cells, turn on. They look at the cell. They look at the vaccine or the virus or the bacteria. They can then create these antibodies against those guys, which then can then stop them in their track the next time that you see them. And over the years, the more and more things that you see, the bigger and bigger reservoir of those antibodies and those cells with memory to those bad guys become. And that's how we build up an immune system over time as we get older and have that kind of memory in between. And then there are some cells that kind of play a role in both of these arms, and those are the guys in the middle. And we'll talk about how all of these cells get turned on, and all of these cells become activated, and they have to talk to each other, and they do that using certain chemicals. And so this is, again, just another way to look at how the immune system is actually triggered. So we start up top at number 1 over here, and we can see that some bacteria, virus, toxins get into the body, whether it's through your nose from breathing it in, or through a cut on your skin. Whatever happens, these bad guys get into the body. And that triggers some of these cells to produce these chemicals that we call cytokines. And cytokines are these proteins that are the signals. They're the signals between these types of cells, telling each of these cells to turn on. And sometimes with certain types of bacteria, certain signals will tell only some of these cells to turn on. And in other ones, all of these guys go crazy and everything turns on. And there's a zillion of these cytokines, and this is what's being learned in research laboratories every single day, as we can find all of these new types of cytokines. And it just tells us how our body has so many amazing ways to try to fight off infections, which really were, the goal of all of this is to fight off infections. And so some of the major players, with these are things called interferons. There are these other ones that are called interleukins, IL-6, IL-12, IL-23. Again, you don't have to memorize this stuff, but it's certainly, these are things that once we learn that they exist and we learn how they signal, then maybe in the future we can say, all right, now let's block that signaling. And if we block that signaling, maybe we prevent those activations of those guys, which obviously we don't want to do if you have an infection, but if your immune system is overactive, that could really potentially help. And so, once those signals or cytokines get turned on, they send their messages to these kind of what we call effector cells, the cells that actually do stuff. And that's number 3 in those cells. They actually get into the bloodstream, they go to the place where the infection is happening, and then they start doing their thing. And so we go back over to the left to number 4, and we can see that these messenger cells, they kind of bind to the receptors, or the messengers bind to these receptors on all these different types of immune cells, both the adaptive ones and the innate ones. And they start doing their job, which is, for the B cells, the types that create the antibodies themselves. And for some of these other ones in the innate immunity side, they release certain chemicals that kind of damage the bacteria and the virus and kind of break down their cell walls and essentially kill them. And so all of these cells work together. They all work, can usually very well. And that's why, when we get sick, we might feel bad for a while, but eventually, we clear the infection and then we get better. Now, lupus obviously is when this doesn't work the way that we want it to. And again, this is where we get into the idea of the immune system. Instead of attacking a bacteria or a virus, it starts attacking your own body by accident. And so overall, with people when they live with lupus, there's both sides of those immune systems, both that adaptive immune system and the innate immune system work not the way that we want to. And that eventually leads to those same cells releasing those same chemicals, but instead of damaging the bacteria and virus, they start damaging our own cells. And that's where we start getting the symptoms. That's where we start getting the inflammation. And so there's a zillion different autoimmune diseases, depending on where that inflammation is actually happening. We talk about rheumatoid arthritis, where most of that stuff happens in the joints themselves. We talk about thyroid disease, which is its own kind of separate issue, but is often autoimmune. I mentioned childhood diabetes, where those immune cells are active against the pancreas, these cells that create insulin, and that's why those people get diabetes and high blood sugars when they're children. But lupus, in a lot of ways, is the prototypical autoimmune disease because it can impact any part of the body. And that's what makes the disease so variable between different people, because not everybody gets all of these symptoms. Most of the time, people get a couple of them, and the person sitting next to you might have 2 different ones, and you both have lupus, but your disease can look totally different. And it's what makes things interesting, but it also is what makes things very difficult in terms of A, treating it, and B, understanding it, and C, getting other people to understand it. And so these are just some of the major symptoms, and you guys know this already. I'm sure you talked about this already earlier today, but the major ones that we think about are the joints in particular, the muscles and the bones, and the skin with rashes. Those are probably the most 2 commonest side effect or symptoms of lupus. But when the disease is more intense, it can really start affecting the organs. And we talk a lot about the kidneys, which is probably the most common organ to get affected. But it can really affect any part of the body: lungs, digestive system, heart, eyes with inflammation in the eyes. And in a lot of ways, the brain is sometimes the worst when that can happen, and the most severe. We have to take that all very, very seriously when any of these symptoms happen. And so there, again, we're learning so much about lupus, how it works, why these things happen, and we're learning about maybe what are some of the more key players. What are the players that seem to be more common in a lot of lupus patients, for example, and we go back to a few of these things that we had talked about, parts of the immune system that definitely seem to be more active and play more of a role in lupus in particular. And one of them is one of those cytokine messenger proteins called type 1 interferon. It's a messenger that stays elevated, and it sends signals to multiple parts of the immune system, and it's constantly on telling the body to attack itself. And then there are those white blood cells that we had mentioned, the B cells and the T cells. They're part of that adaptive immunity part. And the B cells are the ones, again, that create antibodies. And we know that having a lot of antibodies is a big part of lupus. And so these signals will tell the B cells to stay active, stay active, stay active. Even though there's no infection, those B cells are continuing to stay active because they think that something in your own body is foreign. And so those antibodies get consistently produced. And also those antibodies are what we look at when we do blood tests, because we're trying to see certain antibodies can be specific for lupus. And so when we continually bleed you, as we often do as rheumatologists, a lot of times we're looking for specific antibodies that are associated with lupus. And then there's another type of white blood cell, which are called the T cells. And those ones often will kind of crosstalk with the B cells. They'll talk to each other, they'll activate each other. And so that can make the B cells make more antibodies. But also the T cells themselves have activity that can cause damage to your own tissues as well. And so while there's a whole bunch of other or immune activators and parts of the immune system that get active when you have lupus, these are three of the kind of more major players, if you're going to remember anything. And so, there's kind of ongoing research that we have that we're trying to address the drivers of lupus, right? So, we've learned so much. We've gotten a great idea about these B cells, these T cells, the type 1 interferon and other cytokines. And so it's helping us understand what lupus is. And it's also helping us understand what makes different lupus patients different, right? So why do some lupus patients get only skin disease and other patients only get kidney disease, and that might relate to the different types of cells that get activated or the different types of cytokines that get released. The type 1 interferon is one of those things where we know that there are a certain percentage of patients that have that as a big issue for them. And so, maybe targeting that might be the right type of treatment for that patient as opposed to maybe a different patient. And so we're still trying to learn about what, if that's, truly what it's going to take, or how we're going to get to this kind of personalized medicine. But the research that is ongoing, to understand, lupus and really the drivers behind the disease. So we're getting somewhere, but we're certainly not there yet. And so we'll move on to talking about, how we approach lupus, how we treat lupus and what we have now and what we're thinking we're going to be able to have soon. And so before we talk again about medicine, because I don't want things to be about medicine. It's easy to get excited about that stuff, and it's easy to focus on those things, especially as doctors. But we always want to kind of take a step back and remember, what the medicine is for. Why are we using medicines and why are we trying to treat patients? It's not just for numbers to go down. So we talk about lupus, and we talk about lupus as a flaring disease, and so there's often a low level of inflammation that's always going on in lupus patients, but something can trigger flares to happen. And it's easy to kind of associate what your disease is with those flares. But that low level of inflammation that's kind of going on constantly can cause damage, to your organs. And that's what we want to prevent kind of going forward, is that damage from happening. So lowering that inflammation so that even in the times when you're not having an out and out flare, you're still not actually causing damage to your body. And so, these flares can come and go. I kind of mentioned a couple of things that can sometimes drive them: sun exposure, infections, But sometimes it just happens, and we're still not sure why these flares happen. Why did the immune system just kind of ramp up all of a sudden and then calm down on its own just as quickly? And some people can have these flares that last, a day, and other people can have flares that last weeks. And we're still trying to kind of get a gauge on why that happens. But regardless of why and when, we've got to kind of lower down that immune system activity, for the longer term. And so how do we treat lupus? And again, you guys are probably already experts on some of this stuff, but I'll just briefly talk about, what's in the arsenal that we have now. And we start with those anti-malarials on the top left, and those are the medicines that are hydroxychloroquine, you probably all know about. These are medicines that were initially made for kind of malaria, and they were used for people who had malaria or to prevent malaria, and people who had autoimmune diseases started feeling better, and then we're like, okay, maybe there's something more to this. And we found that they're not immunosuppressing medicines. They don't lower down your immune system. They don't make you at risk for infections, which was why we love it. And we also why we use it for everybody. We try, unless there's a reason, a side effect, you couldn't be on that medication, we try to put those medicines on all of our lupus patients. And they're a standard medicine, but they're, as you know, a slow acting medicine. They're not medicines that just make you feel better right away. They take, weeks to months to start working, and, they're not the strongest thing that we have, but they're a great baseline. And we try to have all of our patients on them unless we can't. The steroids, the cause of and solution to all of our problems, are medicines that we use for treating flares in particular, right? When something is bad, we need to lower down the immune system quickly. We use those medications, but we try not to do is use them long term at high doses, because there's a ton of side effects that can happen. Everything from high blood sugar to high blood pressure, weight gain, skin changes, bone changes, increased risk for infections. And so one of our major goals in treating lupus is to get people off steroids if we can, and not have them need to take them for flares that often. Non-steroidal anti-inflammatories, or NSAIDs, are a lot of the medicines that you can kind of get over the counter, like ibuprofen or naproxen. They're used often for pain more than anything else. They're a good stopgap when symptoms are on the milder side, but they're not a long-term answer to treating lupus. They don't really affect the immune system in any sort of long-term way. It's the immunosuppressive medications that are often our step up after we start somebody on an anti-malarial, that if that's not good enough to control their disease activity, we'll need to step up to one of those immunosuppressive medications. And these are the ones that we've had for a long time. And honestly, most of these medications were not created for lupus. We use them, but they were created for other diseases that either increase the immune system, or that if we're trying to decrease the immune system sometimes. And whether those are old like chemotherapy agents that we use in lower doses, or medicines that were created to prevent kidney transplant rejections. Those are, those medicines that lower your immune system so you don't reject a kidney. We can then use them in our diseases when the immune system is too high to try to get it to a more normal level. And so those are the traditional things that we have, but now what's the future really of treating lupus are these targeted therapies. Because we've learned so much about the way that these cells create these cytokines and different cells that get activated, we can now kind of target those things. And a lot of times we'll do them with these types of medicines called monoclonal antibodies. And that's a term that maybe you've heard about now with the whole COVID situation, because we use types of monoclonal antibodies in COVID to try to, bind up the virus to prevent it from really causing a lot of damage in your body. But for years before we use it for that, we've been using it for our autoimmune diseases. A lot of them were used for rheumatoid arthritis. And now, as we're understanding more about lupus, we're creating them for our lupus patients as well. And so there's another term for that you might get heard thrown around. It's called biologics. And again, it's just a way of saying that these medicines were created particularly for the biology of the disease that we're using it for. And so that's where we're going from now. And again, there's differences between these two types of treatments. Those traditional ones, those traditional immunosuppressants, really are there to just knock out your entire immune system kind of broadly. And that's great. And sometimes that's better because multiple parts of the immune system might be turned on at the same time, and using those medicines might be the right way to go. But our hope is that we can figure out what makes one lupus patient have their type of disease, and then target that with a specific medicine that's known that we think will work for that particular cell or particular cytokine that's overexpressed. And so that's where the future is going to be. And so again, just to summarize this kind of part, our overall goal here is to address our unmet needs in lupus. Again, flares can come and go, but lupus stays, and we really want to prevent, organ damage and prevent further organ damage from actually happening. And in doing so, we can then kind of put you in control of your disease, because if there's one thing that patients always ask is, what can I do? What can I do? And it's always such a hard thing to answer, because, some of this is just so out of anybody's control that we need to rely on medications. But once we start lowering down the immune system in a way that's kind of more specific to the patient, then maybe we can start focusing on the overall treatment of the patient, and also finding a way so that if we find the right medicines that don't have side effects, that you feel more comfortable taking medications and don't want to just give up on this craziness. So we'll talk a little bit about where we're going, briefly with lupus management. And again, just to kind of touch on some of these topics we've already talked about, again, what we're trying to get at is figuring out what the right goals are. What are we trying to accomplish? I think we're all trying to prevent the damage from happening. But beyond that, we need to make sure that the patient is comfortable, happy, willing to continue treatment, and wanting and feels like they're able to do everything that they need to do and want to do. And so figuring out what those goals are is a discussion that you're going to have with your doctor. And how do we get to those goals, and what's meaningful, what's reasonable, what can we achieve? So that's one of the major things that I think we're thinking about in terms of reassessing how we treat lupus. Another thing that we're trying to pay attention to is increasing diversity in lupus, and in particularly diversity in some of the clinical trials that we do in order to get new drugs approved and new drugs on the market so that we can use them. And that's just a really important thing, not only because it's morally and ethically right, which it is, but also because we know what the demographics of lupus are. We know that it affects patients of Asian, African ancestry, Hispanic ancestry. All of these types of patients get lupus more often and more severely. And so if we don't include those patients in our clinical trial, then we're not really getting drugs that are for those patients, possibly. Hopefully we are, but we might not be, and we don't want that to be the case, obviously. So there's multiple reasons why we want to increase diversity in lupus. And then again, finding those measures that kind of matter, finding the differences between those kind of clinical successes that we look at, like changes in your labs, as well as the success of different types of patient-reported outcomes of how people feel. And if there's one kind of big takeaway of this whole presentation, is that that's really what we want to do kind of going forward. And again, we're going to talk about this again just quickly, but the improvements of lupus, and how do we measure that? And there's different ways that we look at this, and some of them are blood tests, which I'll talk about, treatment changes, how you feel, those patient reported outcomes, and then those disease kind of measurement tools, which are more for us as doctors when we're trying to get a sense of if somebody actually got better. And so, I want to kind of quickly talk about labs, right? Because if there's one thing that rheumatologists love, is to check labs. We check them at every visit, because some of those tests, some of those antibodies, some of those proteins that get elevated or abnormal when you have lupus, they can track with the disease. And so we can check them at every visit and we can see, are things getting better and things getting worse. And we love it when we see things getting better. We put somebody on a new medicine and the labs get better and we're like, we did our job, we are awesome, and it makes us feel great. But the truth is, sometimes you get lab work that gets better and people don't feel better. And we need to take that into account. And on the flip side too, there are some people where the labs never get better and they do feel better. And that's important too, to not get caught up on labs and trying to give people more medicine if the labs aren't getting better, even if you as a patient are. So these are things that we definitely need to kind of keep an eye out on and kind of check ourselves, both the doctors and the patients together. On the flip side of that, your labs might not get better, but you might feel better. We might be able to lower down the actual amount of medicine you have, which I think for a lot of patients is one of the ultimate goals, is how do I get off all of these medicines? And so, if we can reduce symptoms to the point that we can then come off certain medications, that's a win, and that's something else that we want to just keep in mind, as we go forward, as to what are successes, what does success mean? It's not always just lab tests. It can be, making your life easier. And then I'll just briefly talk about this patient-reported outcome idea, which is really cool because this is something that's been embraced by, I think a lot of companies when they create trials, and even the NIH when we're doing trials through, the government-funded trials, that we really are trying to take the patients. How they feel about things as a major player into what is, success. And so these PROs are essentially questionnaires that come from the patients. They speak to what the patient feels, how they feel physically, but also, mental, emotional, fatigue, these types of things that are really the things that impact patients the most. And we're trying to take that into account when we say, does a drug, for example, work? Certainly we can look at those measures like labs and say that it does, but if it doesn't really affect these patient-reported outcomes, did the drug really work? And so that's getting that part of this kind of into how we measure both how patients are doing and how drugs work is really kind of the next frontier. And it's not perfect yet. We're still trying to find the right ways to do this, but at least the acknowledgement of that is a good thing. And so, just a few final key takeaways. Want to take a step back as we think about all of the issues that are still ahead of us, to remember that we've come a long way. Just the understanding of these different immune abnormalities in lupus was a huge step, and now having some medications that actually can affect those is amazing. Honestly, it's the disease now is not what the disease was 10, 20, 30, 40 years ago. It's a completely different disease that we can manage in a completely different way. So that's huge. So we definitely want to be happy about it, talk about how, every time you've done a walk or raised money or even told somebody about lupus, how that has kind of trickled down to this point where we have medicines that are available and more medicines that are most likely going to come out. So definitely want to celebrate that. We've learned a lot more about lupus and how it works, and that's going to give us, that next step so we can get even better medicines in the future. As we get those medicines on board and as we start being able to kind of deal with that acute inflammation, I think the next step becomes, okay, how do we treat the whole person, not just medicines, not just labs? How do we actually make sure that what we're doing is benefiting you and your ability to do what you want to do in the day? Because those physical and those emotional aspects of lupus are highly connected. And, we're still looking at that and still trying to get a better sense of the fatigue and things like that. Those are unanswered questions. So that's where we're going. And so again, I just want to thank you for listening and paying attention. And, if we've got some time, I'll definitely take some questions. I don't know if anything's in the chat, but feel free to fire away.
Wonderful. Thank you again, Dr. Saxena. We really appreciate your time, and that was really so much information that just is wonderful to have. And hopefully everybody walks away today with a better understanding. So we do have a couple minutes, so please feel free. If you have anything on your mind, you can either type it in the chat, or feel free to come off of mute as well, and ask Dr. Saxena your question directly. If not, we'll do the really fun, awkward wait for that.
I'd like to believe that was just so clear that there was no possible questions.
Here we go. So we have a question: are there any prednisone-like medications without the prednisone side effects, such as moon face, appetite increase, etc.?
So I wish I could say yes, but the answer is no. The issue with prednisone, the benefit of prednisone is that it works really quickly, right? So we don't have a medicine that works as quickly because the ones that we focus on the immune system, that those targeted medicines, to kind of change the immune system takes a long time. It really takes a while for the immune system to kind of quiet down. The prednisone is great because it does it quickly, but it won't last long, or we can't use it for a long time. So I wish that I could say that we have. Now, this is, again, something that is being more and more looked at with some of these new medicines, because the idea, hopefully, is that some of these newer medicines might work faster and allow us to, what we could say, spare steroids more quickly. And so our goal is to minimize the amount of steroids, prevent those side effects from happening, but still use them in the short term while the other medicines start working.
We have another question. Do you think a cure would benefit those already living with lupus and have suffered damage?
I do think so. Damage by its definition is something that's unchangeable, right? So while I don't know if a medicine like that would reverse damage, I think when people who live with lupus, as I kind of mentioned, and they've had damage already, but they don't have those flares, there's still that ongoing inflammation that's going on. And so I think if we could find a medicine or something that can cure lupus, that would prevent, further damage from happening. And again, as we learn more about some of those other symptoms that we haven't really figured out, like the fatigue, which I know is like the big thing, if we can get at that, certainly on the day-to-day, I think that would be a huge lift for our patients.
And we have a lot of us have crossover conditions. How do you treat and create a treatment plan?
Yeah, it's a great question. And so this is where, I think having a little bit of a, of a broader view of things can be important, because autoimmune diseases can be, if you have one, you can have multiple, and the symptoms of some of them can overlap significantly. And so I think some of the like obvious ones you might see, like rheumatoid arthritis, for example. You might get rheumatoid and lupus, and there's so many medicines for rheumatoid arthritis out there, and you've got to find the right one, because some of them you can't use in lupus, and other ones we think actually work for lupus. And so, it's kind of picking and choosing in terms of medications, what might work for both. And so that's obviously a discussion that you'd have with your rheumatologist for sure. I think the broader ideas of certain things that can overlap and treating things like, for example, dryness that can happen with Sjogren's syndrome from lupus and Sjogren's syndrome, that's another thing that we also want to just kind of, think about, does our medicines actually help for that? Or should we talk to like eye doctors for different types of drops and things like that. So I think having a multiple or multidisciplinary team, when you have those overlapping conditions, is important. So other doctors that kind of focus on other parts of your body too.
Great question. I know we're probably cutting over soon, but let's try and squeeze this question in. Are biologics impactful for people who already have lupus-related autonomic nervous system disease?
So the short answer is we don't know. I hope so, but the autonomic nervous stuff is still very much a black box. I'm not going to lie. I'm not going to pretend otherwise. We're still trying to figure out how that overlap happens. And if medicines to lower the immune system will work on that stuff. We don't know, but I'd like to believe so. And I think if we do more research on why that autonomic nerve stuff is happening, maybe we find that cytokine, for example, that is abnormal in that particular manifestation, and then we can target that. So I think there's still a future for that to help, even though I can't say that yet.
Great. All right. Awesome. So we're going to switch back in about 50 seconds. But again, Dr. Saxena, thank you so much for your time, and AstrZeneca for being here. We really appreciate it. And thank you all for your thoughtful questions. We'll see you back in the main room.
Thanks, everybody. Thanks.